My research covered serving clients in Central Appalachia, self-efficacy of mental health counselors, and assessing and intervening on alcohol and substance use. Throughout Appalachia, the one gift that doesn't insult anyone is whiskey. We're known for moonshining. We're known for being backward and uncomfortable with change. So this again sets the stage for what we're looking at. Here in Appalachia, we're very impoverished. We're impoverished economically. We're impoverished cognitively. We actually think in a box more so than maybe other parts of the country. It's important that counselors be accountable to the well-being of their clients. And here in Appalachia, that's a challenge because transportation is an issue. People wanting to come and be noted, stigmatized as crazy, that still exists here. And so all that being said, the bigger problem are training deficiencies. We have clinicians that have gone to college and this and that, but there are very few of us. And so we have almost a dearth of what is available. So despite lots of resources not being available to us, we address here in this part of the country some pretty complex issues. Poverty is the baseline. Homelessness is occurring. Substance use, we've made national and international news because of. We have a lot of chronic illness because we have healthcare disparity, and there's quite a bit of disability. My study looked at Central Appalachia, which includes Eastern Kentucky, Southwestern Virginia, most of West Virginia, Eastern Tennessee, and Northwestern North Carolina. I used social learning theory that indicates that people that are self-efficacious can self-organize, conceptualize, reflect within self, and regulate themselves. I also looked to Hofstede. Childhood experiences of disadvantaged learning is filtered through transference of a collective mental program that result in life being impacted and many life consequences. And Cunningham in Apples on the Flood in 1991 wrote that the internal dialogues of exclusion, hardship, and retaliation actually are a transgenerational issue for Appalachians, and they result in the worldview manifesting well below the Van Dorten construct. So what are the issues that I addressed in my research? Appalachians at the time were dying by the droves. Methamphetamine and opiates remain a crisis here in our area, and fatalities continue to occur. Co-occurring mental illness is also an issue. Nearly half of the adults reporting substance use have mental health issues. And co-occurring treatment is actually a novel concept in rural communities and is that way here today. So fighting against a cultural misnomer of that substance use is okay, it's part of our norm. Drinking isn't a problem and we deal with lots of issues, so let's get away from them. This is especially challenging here in Central Appalachia. According to Hall and his colleagues, rural substance users have less than half the opportunity for treatment despite the levels of substance use. Here in rural America, we have a tremendous problem, and it's actually surpassed many urban locations. So, and a need exists for our counseling professionals to be able to assess when they have the person in the office for not only a co-occurring problem, maybe we also have homelessness, but we are often affected by substance use. If it isn't the individual in front of us, it is a family member. So are the counselors prepared? In the Appalachian social strata and the layers within the underclass of substance use, there's an endemic problem. It exists in the culture. Drug use fatalities have more than doubled in the past 10 years, and that number has continued to increase despite medication assisted treatment programs and law enforcement involvement. So there's a need, again, I repeat myself, for counseling professionals to be able to assess and intervene on the effects and signs of substance use or co-occurring disorder that involves substance use. So my question was, what is the counselor's confidence about providing substance use intervention, and what actually would help build the confidence if it is actually in existence but a little waning? So my first hypothesis was that mental health counselors in Central Appalachia would actually report low levels of perceived self-efficacy to provide those services. And this was directly involving my employment at the time as a clinician. I worked within an area of a lot of social workers in the facility and organization, and they wouldn't oftentimes assess for this substance use problem. They would refer them to me, and my caseload boomed a lot. My second hypothesis was that factors that might affect counselor self-efficacy would include level of education, credentialing, how many graduate substance use classes were offered and completed, how many continuing education hours occurred in substance use, the length of their time in the field of counseling, and the length of time that they could identify having worked with some substance using individuals. So what were my variables? Again, my 7 predictors are listed, and I've named those just now. I used a scale called the SATSIS, the Self-Efficacy Assessment of Treatment for Substance Use Efficacy Scale. So the subscales were about ethics, assessment and treatment planning, case management, individual counseling, and group counseling. And throughout the instrument, it would ask, how confident are you in? And then name the question. There were 32 items with a 5-choice interval scale from very low at 1 to very high levels of confidence at 5. Barriers that were found included fear, religion, disgust, and some other comments. There was a 5-part Likert scale provided around the self-efficacy, 0 being completely unable due to their experience or belief that they could intervene. 1, these counselors would be willing to try to intervene, but they would have some fear. 2, they would be pretty comfortable and had some interest in helping substance users. And the 3rd would be no concern whatsoever. Come on in, let's talk about whatever's bothering you. There was a homogeneous sample of 65 licensed mental health counselors that responded. They were from Eastern Kentucky, Southwest Virginia, and West Virginia. 55% had worked as counselors for at least 10 years or less. 53% reported only 1 graduate level substance use course, and 54% reported less than 16 substance use continuing education hours. There were 54 female participants, which certainly supports Dr. Wallace's comment, 21 males. So there is definitely a deficiency in males coming to our career field. And the age group was from 26 to 55 in the respondents. The barriers that were reported to people feeling self-efficacious as counselors in substance use issue, as you can see, there were people that said none. Other people said lack of experience, knowledge, or training. The numbers there are the number of responses. 6 were fearful. Others felt that treatment was ineffective, they had too short of a time, or they were concerned about relapse. Lack of funding and resources played a huge role here, as it always does. And religion, 2 people said they couldn't deal with substance use because of that. Others didn't want to deal with challenging mandated clients. Others said maybe they would have some countertransference. And one individual said that they were disgusted and would not work with these individuals. I'm going to have to move us. Our Cronbach's alpha was reliable at over 0.6. Case management was at 0.9. Assessment and treatment plan 0.91. Individual counseling 0.9. Group counseling 0.94. And ethics at 0.85. And this was through the SATSA scale. Continuing education and substance use was my strongest predictor in this study. We need more education on intervening, assessing for substance use. My milestones included that counselors that responded to my request to be involved were actually quite efficacious in providing these services. Competencies exist. At a minimal for co-occurring treatment services. There just isn't enough. And so what's next? We need to increase the training and professional development opportunities for any human service counseling provider, but especially around substance use. What were the takeaways from my study? That Appalachia is a very distinct culture with normalized acceptance of substance use, both in origin and ancestry. That there's an immediate need for assessing co-occurring issues and providing treatment around the substance use issues here, because the current rates of substance use actually normalize this for future endeavors. What else is needed? Education, continuing ed, professional development. These issues are going to inroad the change in perception and intervention and maybe decrease what is currently an epidemic. So I tell you, the time for educated action is now, because the duct tape offered in mental health programs that aren't assessing for co-occurring is not working. There are trends now to decriminalize marijuana. In fact, that law comes on the book in Virginia, July 1. Corrections is the response to most methamphetamine use. And unfortunately, people die on the regular. The obituaries are huge. So we need to be trained. We need all professionals to receive some training. Unfortunately, as of the writing of my paper and the completion of my research, which was 2019, until now, that need continues to be unfulfilled. I thank you for your time, and if I can answer questions, I'll be willing to do so.